Welcome to the Neurology Live Mind Moments podcast. Tune in to hear leaders in neurology sound off on topics that impact your clinical practice. I'm your host, Marco Meglio, editor with Neurology Live. In this episode, Dr. Jessica Ailani, director of the MedStar Georgetown Headache Center, joins us to discuss new phase 2 findings on Bocunebart, a PACAP-targeting monoclonal antibody being developed for migraine prevention. Presented at the 2026 American Headache Society annual meeting, the pivotal PROCEED trial evaluated the therapy in patients with episodic or chronic migraine who previously failed multiple preventive treatments. In this interview, Ailani reviews the efficacy and safety findings, discusses new data on the Coadministration with ubrogepant, and shared her perspective on where PACAP-targeting therapies may fit within the future migraine treatment landscape as the program advances towards phase 3 development. Let's dive in.
So this was a phase 2b trial taking a look at an anti-PACAP molecule. So PACAP is another neuropeptide that we know is heavily involved in the pathophysiology of migraine and also possibly in cluster headache. And blocking PACAP potentially has the ability to reduce migraine frequency and stop a migraine attack. So this study was taking a look at a monoclonal antibody that binds to the PACAP ligand, blocking its activity with the hopes that it would reduce migraine frequency. So really looking at it as a preventive treatment. This is the second phase 2 study looking at an anti-PACAP ligand, both within the same molecule, Bocunebart. And this particular study was looking at patients who had episodic or chronic migraine who had tried prior preventive treatments and found them to be unsuccessful. They could have tried anywhere from one preventive up to 4 different preventive classes. So we would consider some of these patients to be refractory migraine. And it's really great that there was a study looking at this. The main primary endpoint was taking a look at reduction in monthly migraine days from weeks 1 to 12 during the study interval. And we particularly were looking at an intravenous infusion of this monoclonal antibody given once a month. And they had 3 treatments during the time of this study. And so we were comparing their baseline to the end of that trial time period over the course of the trial to see if there was a reduction in migraine days. And of course, it was a positive outcome. And we found that there was a reduction in a particular dose. This was a dose finding study of about 1.38 days less compared to placebo. So that was the therapeutic gain of about a day 0.38 less in migraine compared to the baseline period. So really, really exciting signal. And we can think about how we're going to take that forward in phase 3 trials. Just to also give you a little bit more information, as I said, this is a second phase 2 trial looking at this particular product. So we wanted to pool the analysis in what we would consider our highest burden patients, those with chronic migraine, from the PROCEED trial looking at this intravenous PACAP monoclonal antibody, and also take a look at the other phase 2 trial, which was called the HOPE trial. And that looked at an intravenous infusion of this PACAP monoclonal antibody, but only one dose. And they looked at a time period of 4 weeks. And they only focused in on chronic migraine patients. So we have a wealth of data looking at chronic migraine that have tried prior preventives and not found it effective. And we see in this pooled analysis overall that there's this reduction in monthly migraine days that trends from month to month during that course of 12 weeks. We also saw there was a reduction in acute medication use, which is what you want to see if migraine days are going down. And then we saw that there was also a reduction in headache days, which I think is very important because migraine gets better. Does low-grade headache, intermediate headache go away as well, or is it just one or the other? And here we have the whole package where there was reduction in migraine, headache days, acute medication use, and then patients had better patient-reported outcomes when measured using MSQs. So really, really exciting findings.
Yeah, absolutely. I know obviously this is a new kind of mechanism of action. So to see it kind of, obviously, I know it's kind of a big hope sometimes. We're waiting. And obviously to get the positive findings is very, very encouraging. Also, like you mentioned, this is obviously a group that has, failed some preventatives before in the past. So to know that it's kind of breaking through a little bit for some of these patients is obviously a big deal. Talk a little bit about, we've obviously kind of touched on the efficacy side of things, but would obviously like to talk a little bit about the safety. So just quickly give a little bit of an overview of what the safety showed and any considerations or signals that clinicians who might use this drug in the future, what they should kind of be aware of.
Yeah, so generally this was seen as a well-tolerated treatment. Now we have these 2 phase 2 trials and almost, and I'm really estimating here, almost 1,000 patients between these trials that have been treated with either Bocunebart or placebo. And what we're seeing is small changes, nasopharyngitis and upper respiratory tract infection. And the rates are somewhere like 5.7% for the pooled analysis in the nasopharyngitis group compared to 4.8% with placebo, and 1.6% of upper respiratory infection compared to 3.6% with placebo. So actually really, really exciting because, of course, if something works but comes with a host of side effects, that's just probably not going to take us very far in clinical practice. But to have something showing efficacy with this kind of safety signal, it's really very exciting.
Yeah, obviously that's another kind of leap that we always have to jump as well. One other part, I know we're obviously talking about the PROCEED trial, but the other presentation that was presented at AHS was also very, very interesting, kind of looking at Bocunebart co-administered with ubrogepant. So give a little bit of background on this study, how and why this study kind of came about, and just a little bit of an analysis on what the results actually showed themselves.
Whenever we're bringing new therapies or have an idea we're going to bring a new therapy to market, a very important factor right now is how is it going to interact with other treatments out there? Though we know that PACAP is an individual mechanism in migraine that is separate than CGRP, their mechanistic areas of activity, this is really a simple way to put it, are close by. And the receptors are both located on smooth muscles. So there has the theoretical potential that when you start blocking all these receptors or the ligands, is it possible you could start to trigger things like a higher blood pressure or a change in EKG or any kind of vascular risk issues? So it's important now going forward that all of these types of molecules do have these kind of concomitant studies where they're looking at something that's going to be used frequently alongside the treatment. And for an anti-PACAP treatment, it's no big surprise that we're probably going to use anti-CGRP treatments in the same patient. So ubrogepant is an oral antagonist of the CGRP receptor that's used as needed to treat a migraine attack. And it makes the most sense to study that alongside with Bocunebart, really to see if a patient's on both, are there any signals of safety concern? And so these patients were given repeat doses of ubrogepant, then given a dose of the Bocunebart, and then evaluated to see if there was any changes in blood pressure, EKG, or any kind of adverse events that came out. And also what happened to the PK of ubrogepant. What we saw, there was no PK change in ubrogepant, which is a theoretical model of saying probably clinically it was just as effective. We didn't see any kind of signals for blood pressure changes or cardiovascular concerns. And so I think it was a really important type of study to perform because we know these things are going to be used together. And I think a marker of how we need to start to think about layering and combining our therapies in the future and how to study them.
We're going to take a quick break from our conversation with Dr. Ailani to keep you up to date on the latest developments in neurology. Welcome to the Neurology News Minute. Here's what you may have missed since our last episode. First, on June 1st, Biohaven reported new clinical data on opicalum, its investigational selective Kv7.2/7.3 potassium channel activator in several different patient populations, including idiopathic generalized epilepsy, focal epilepsy, and KCNQ2 developmental and epileptic encephalopathy. The findings were unveiled ahead of the company's annual Research and Development Day and come as Biohaven prepares for top-line results from the first of 2 pivotal Phase 2-3 focal epilepsy studies expected in the second half of 2026. Next up, in the same week, the European Commission approved atogepant for the acute treatment of migraine in adults with or without aura, expanding the therapy's label beyond its previously authorized preventive indication. With the decision, atogepant became one of the few CGRP receptor antagonists approved in Europe for both the prevention and acute treatment of migraine. And lastly, at the 2026 AHS annual meeting, investigators presented positive data from the Phase 2b PROCEED trial, the same study that Dr. Ailani breaks down in this episode. All told, treatment with Bocunebart, a PACAP-targeting monoclonal antibody, led to significant reduction in monthly migraine days, along with meeting the trial's primary endpoint. For more information about these stories, head to neurologylive.com, or you can check out the corresponding link in the show notes. And now, back to our conversation with Dr. Ailani.
Well, like you said, obviously these are going to be things that in the real world, they're going to be kind of used in conjunction with each other. So we might as well test to make sure that they are all good to go before we actually do that. I'm also curious, Dr. Ailani, I know obviously there's some small differences between some of the CGRP therapies. So why in particular did you guys choose ubrogepant out of all of them, or was there really no major reason for that?
I'm not sure there was a big reason. I think they were using and looking at an acute treatment because that makes the most sense, that most people on Bocunebart are going to end up on really needing an acute treatment, and it's sensical that it would be a GPANT. There's a theoretical of maybe the CGRP, if we block CGRP and PACAP, is that going to be in any way harmful? You want to do this the first time in a molecule that comes and goes out of your system, right? I really wouldn't want to give someone a monoclonal antibody CGRP blocking agent and an IV PACAP and then see there's a problem and now it's going to take months for it to clear the system. So I think it's a smart way to go with a molecule that has a very short half-life. And if you look at the GPANs, ubrogepant has the shortest half-life theoretically compared to rimegepant or zavegepant as an acute option, and certainly much shorter half-life than any of the anti-CGRP monoclonal antibodies. Now, does that mean I wouldn't want to see a study looking at how a patient who's taking an anti-CGRP treatment for prevention does while they're on an anti-PACAP? I definitely want to see that, but more in that phase 4 realm. So after these treatments have made that leap of the hurdle over the phase 3, and we really see a stronger safety signal because there's so many more patients exposed to it, then you want to start looking at the idea of combination therapies, not only for safety, but what is the efficacy? How much more efficacy are we picking up when we combine these preventives together compared to someone who's just on a single agent alone? Because again, if we're looking at our patients who have refractory disease, many of them are going to have a partial response to anti-CGRP therapy. We're looking at like a 30% improvement. 30% in someone who has chronic migraine. It's good. It's really not great. And it's not what our goals are. If we look at our International Headache Society's recent guideline publication that we really want to aim for 4 or less migraine days per month, we really need to start looking at these therapies in a combination way. But I think to start, this was the smartest and probably best way to go.
Yeah, I'm sure there will probably be studies that I'm sure you'll also probably have a hand in down the road as well once we get to that point. But obviously we can save that for when the drug is hopefully approved in and of itself during that time. Dr. Ailani, last question for you. You obviously, and I don't know how much detail you're going to be able to give about this, but just talk a little bit about what some of the considerations might look like for a potential phase 3 trial for this drug. What are things that you and your colleagues are, making sure that you are trying to factor in when designing this trial? And also, what are some of the, unknowns about a phase 3 trial with this type of drug that, we haven't gotten to this point, thus yet with the PACAP targeting drugs?
Yeah. So, the first consideration is who's this patient population we're going to look at. The stronger signal is looking at the chronic migraine group. Does that mean it's not going to work for a pure and simple episodic migraine patient? What about the refractory episodic migraine patient, the person who's got 6 to 8 migraine days a month, has tried various treatments, they haven't been effective? I think that's the group we're going to have some questions about, but might not be that group that gets into that phase 3 trial. The underlying question that comes out of this is this more effective in a refractory group, or is that just a better patient to start a study on because the placebo rates are a little bit more manageable? There's a lot of back and forth conversations about, is it that they're centrally sensitized and PACAP seems to work a little bit better, even though it's a peripheral agent there? Is it because maybe they're just a better patient population to study right now with all the dearth of clinical trials that are ongoing? There's just lots of noise in the environment. So I think that's the first thing that has to be figured out. What's the patient population? What numbers do we need to look at? How many treatments should they have tried in the past? And is there going to be a percentage of patients enrolled in the trial that are treatment naive. I'd really like to look at how does someone who's never been on treatment of any kind do with this molecule. And of course, I would love to know, are there predictors? Can we get a sense who's going to respond to this treatment or not? So can we build into the phase 3 program some questions we can ask the patients to really try to gauge what phenotype of migraine they have that might differentiate the responders from non-responders? Always it's hard because clinical trials can look a little bit homogeneous when you put them all together. We generally have women in their 40s who are white. So sometimes we're not going to get that phenotype we're looking for, but it is nice to think about building these questions in and seeing if we get a sense of a responding population versus non-responding.
Thanks for listening to this episode of the Neurology Live Mind Moments podcast. To support the show, be sure to rate, review, and subscribe wherever you listen to podcasts. And as always, for more neurology news and expert-driven content, visit neurologylive.com.